Okay, we should be live.
Okay, yeah. Yep.
All right, I'll just hang up.
Okay.
All right, how's everybody doing? um, Barb, if you can hear me, send me a text. Just want to make sure that this is going out to everybody. Um, anyway, I guess what we decided to speak about a little bit today is the topic of CRPS. So that's a condition. The acronym stands for Complex Regional Pain Syndrome. This has been divided into a type 1 and a type 2 category, and that's the way it stands right now. These are new names for older conditions. CRPS type 1 used to be the RSD, or reflex sympathetic dystrophy. CRPS type 2 is the new name for the previous term known as causalgia. Now, what's the difference between CRPS type 1 and CRPS type 2? Clinically, the interesting thing about this is that clinically, there's really no difference. You cannot tell somebody apart based on a type 1 or type 2 designation when the way that they present clinically, the things that they complain about, all that is virtually identical. The difference, or the reason why somebody may end up as a type 1 category as a type 2 category, is based on the ability to identify a peripheral nerve injury. That's the key difference. About 90% of people that get diagnosed with CRPS type 1, or excuse me, about 90% of people with CRPS or who get that diagnosis fall into the type 1 category, and only about 10% of people who are diagnosed with CRPS are given a type 2 designation. And so the interesting thing about that, if you just think about it logically, is if you have a condition which presents virtually identically, clinically speaking, so you can't tell just from listening to the patient tell you what's wrong or looking or examining the patient, why is there then this designation between the two groups? It would seem based on clinical parameters and physical exam parameters and history parameters alone that you're dealing with just one condition. And yet the medical community has sort of arbitrarily the medical community has sort of arbitrarily broken it out into these two different classifications. And I would submit to you that the reason why 90% of people with CRPS are given a type 1 classification, meaning no known peripheral nerve injury exists, versus only 10% being given the classification of type 2 or CRPS type 2, meaning a peripheral nerve injury has been identified. The only reason for that huge discrepancy is that most doctors have no idea how to identify a peripheral nerve injury or don't know what they're looking at when they see somebody with peripheral nerve injuries. There's been a couple of good papers published by my mentor, Dr. Dellon, showing that in fact at least 80% of patients who are designated as a type 1 CRPS case really have an identifiable peripheral nerve injury that can be surgically corrected and thus relieve or vastly reduce the amount of pain that the patient is in. It's interesting, if you go to the, I believe it's the Mayo Clinic website, and look at what they talk about for CRPS and what the causes of it are. They go through the designations of type 1 and type 2 and how there's no identifiable peripheral nerve injury in type 1 and how there is in type 2. And then they go on to list like the usual sort of scenarios that people develop CRPS. They list things like a crush injury to the limb, prior surgery to the limb, a cast or something being applied to the limb that's too tight, or there's swelling after it's applied and then it becomes very tight. I don't know of three better ways to develop peripheral nerve injuries than those three described. And so they're effectively saying, well, this is what leads to CRPS, and those conditions are prime conditions for developing peripheral nerve injuries. And then they say, well, we don't know what 90% of the cause of CRPS is. So CRPS, generally speaking, is sort of a death sentence for most patients. Once the moniker of CRPS is attached to somebody's medical chart or medical history, it's almost impossible to get rid of it. The other sad thing about patients being diagnosed as having CRPS is that the general dogma that prevails, maybe that's not the right word because it's certainly not a truth, but the general belief within the medical community is that there is no treatment available for CRPS. Once you have it, you basically just have to learn to live with it. Now there are a few patients who go into remission and those sorts of things. So anecdotally, there's not everybody will have it forever, but the vast majority of people, it never goes away. And the whole treatment paradigm basically, once somebody has CRPS, is therapy to learn how to live with the pain. You know, you can try sympathetic blocks and try ketamine and, you know, infusions or comas. There's some things that can be tried, but for the vast majority of people, those are ineffective. And so that's why the whole mantra of, you know, you just have to learn how to deal with this pain is so widely pervasive within the community that sort of sees these patients. Ironically, the one thing that is most strenuously fought against, or at least the idea, is that of treating somebody who has CRPS with surgery. You know, everybody's told that you cannot do surgery for CRPS because that'll only make the situation worse. And my guess is that that's something that's been born out of sad experience. Because if you have an orthopedic surgeon or a general surgeon or a spine surgeon or really any kind of surgeon operate on you once you have peripheral nerve pain, or once your pain is coming from a peripheral nerve source, if you have anybody who doesn't really understand the peripheral nervous system try and operate on you, almost certainly you'll be worse, because they're never going to address the right problem or even probably figure out what the right problem is. And one thing that's for sure is if you try and address CRPS pain by doing surgery, and the surgery is not addressing the underlying peripheral nerve problem, but maybe close to that area, it's overwhelmingly likely that the inflammation, the trauma from that additional surgery will only make the underlying peripheral nerve problem worse. And so my guess is that that's where the idea that you can never do surgery on a CRPS patient has evolved from. And in that sense, you know, that's right. You really shouldn't let somebody who doesn't understand peripheral nerves to operate on you if you are showing signs of neuropathic pain, because almost certainly it won't help the problem. So another interesting thing about CRPS is that, you know, there's what's called the Budapest criteria, and these are actual criteria that the International Pain Society comes up with, and they have big meetings about this to decide, you know, how do we sort of diagnose officially somebody with CRPS. And there's kind of a complex, you know, list of criteria that people have to meet in order to officially justify the diagnosis of CRPS. In reality, most people, I would say, who end up with the diagnosis of CRPS have never actually been put through that protocol to see if they actually technically deserve the diagnosis or not. In most cases, what happens is you have somebody who has some kind of traumatic injury, or maybe they have a surgical procedure and then go on to develop, you know, CRPS. And what happens is they get seen by, you know, one doctor after another, their orthopedic surgeon, pain management, whatever. And eventually, you know, it gets very frustrating because nobody has any idea where the pain's coming from. And so they just throw their hands up and say, well, it must be CRPS. And then that gets on the chart, and then that just follows the patient forever. So most people, I think, who end up with a diagnosis of CRPS have never actually been even evaluated correctly by the standards that are put in place to diagnose somebody with CRPS. Um, the when somebody initially has a peripheral nerve injury, and especially in patients who sort of fall into this CRPS-like category and are at high risk of developing CRPS, there's very often a very robust sympathetic motor response to the underlying peripheral nerve injury. And what happens, and so this is where you get some of the visual manifestations that you can get early on in a CRPS type patient, where you get, the flushing of the skin, the shininess of the skin, the limb turning red or different colors, the allodynia, where even wind lightly blowing across the limb can be very painful. All these kind of symptoms. And so early on in the course of somebody who's having CRPS, it is important to try and calm that sympathetic response down. And that's where sympathetic blocks and epidurals and these kind of things can be effective. The better way to think about CRPS is that CRPS is sort of like a forest fire that you're viewing from a distance. The thing that you see is really the smoke. And these are the symptoms that manifest clinically that are obvious to the naked eye. Unfortunately, what happens in the way that CRPS patients are treated is that everybody focuses on trying to get rid of the smoke. It'd be like trying to fight a forest fire by just continually sucking the smoke away, but never addressing the actual fire that's creating the smoke. And the key to understanding CRPS is that in the vast majority of cases, there's a peripheral nerve problem, or very often a set of peripheral nerve problems, and that's why patients that fall into that type 1 category where they can't identify a peripheral nerve problem, it's usually because it's a complex peripheral nerve problem involving more than one issue or more than one compression problem, and very often it's a combination of nerve compression and injured nerves. And so it very quickly becomes too complex for regular doctors, even if they do understand a little bit about peripheral nerves, to identify. Patients who are going to end up in that type 2 category where a peripheral nerve injury has been identified are typically patients that have a more simple type of injury where the symptoms are more referable to a specific single peripheral nerve distribution, and therefore it's more obvious and easier to pick up on, and so they may end up with that type 2 designation. It could also have to do with the injury mechanism, like let's say somebody sustains a laceration to the forearm on the radial side just above the thumb, and then they're numb and painful in distribution of the sensory branch of the radial nerve. That's going to be something that's going to be picked up on more quickly. So you have, with CRPS, you have typically an underlying peripheral nerve injury, and then you have a sympathetic motor response. So that's a part of the nervous system that responds. The neurotransmitter in the sympathetic motor response is norepinephrine. That's what causes the changes to the skin and the flushing of the skin and these types of things. But the thing about norepinephrine is that if it's allowed to sort of flood an area continually, it's also a nociceptive stimuli, meaning that the chemical itself, a hormone itself, can then start to irritate other nerves. And this, a combination of this locally, as well as probably some interaction through the central nervous system globally, can cause these situations where it appears that CRPS is spreading, where it was in a more defined location initially, and then it starts to spread to involve the whole hand or the whole limb, and then seems to be spreading to the opposite limb, etc. So spread of CRPS typically has more to do with local persistence of norepinephrine, which can then irritate additional surrounding nerves. and some type of mechanism which we don't understand well through the central nervous system, which then starts to allow the patient to perceive pain in an opposite limb that wasn't originally injured. And that actually is a phenomena that can happen in patients who have severe peripheral, it's like severe chronic pain in one limb, but haven't been diagnosed as a CRPS sufferer. That's something that I see very common, where somebody, let's say we talked about last time about piriformis syndrome, somebody has severe sciatica pain in one limb, and after a year or 2 years, or some usually more prolonged period of time, they can start to experience mild symptoms of the same type in the other side, and can even go on to develop the nerve compression on the other side over time. And some of that's probably centrally mediated, and some of it's probably due to compensation mechanisms because they change the way they walk, etc. So again, understanding that the primary thing that's going on is almost always the peripheral nerve problem. It's really critical in patients who are showing signs of CRPS to address the sympathetic nervous system response, but also to be evaluated in a timely fashion to see what the underlying peripheral nerve problem is. So if somebody's having a really robust sympathetic motor response, it's better to try and calm that down with sympathetic blocks, the cervical sympathetic chain, epidurals, that type of thing. Try and tamp down that sympathetic response, but that won't make the pain go away. It may make certain symptoms in the sympathetic motor response go away, but it's not going to usually resolve the entire problem. Sometimes it does, and again, with any peripheral nerve injury, it all depends on the severity and the degree and factors like this. So, it's good to address the sympathetic symptoms early on with injections and steroids, as it could in some patients make the problem go away. It won't do that in the majority of patients, but it's good to try and tamp those symptoms down, even if it doesn't make all the pain go away. And then the next important stage is to identify what the combination of peripheral nerve injuries are. Again, going back to that idea that you can never operate on patients with CRPS other than to make them worse is just not true. I operate all the time on patients in my practice who have been given the CRPS diagnosis, who have great outcomes. Again, partly that's just because they're given the diagnosis without actually meeting the criteria. But either way, even patients who meet the criteria, most of those patients, at least 80%, will have some kind of underlying peripheral nerve problem that can be resolved. And I guess that would just be my main takeaway about CRPS is it's not a death sentence. Many people who have been given the diagnosis of CRPS can be completely cured with the appropriate surgical approach, and that's heretical. That's a heretical statement among the CRPS community. Most of them, there's patients in the peripheral nerve group that Barb administers that have actually been kicked out of their own CRPS groups because this is the sad thing. It's such a firmly held, almost religious belief in those groups that anybody, even if it's them personally that has had the experience of, I had CRPS, I was operated on, and now I'm better, they're just looked at like you can't be telling the truth, or a very common thing will be that their administrator in that group or others will accuse them of never having CRPS in the first place. So you didn't really have true CRPS if you got better with surgery. So if you're a person with CRPS and you can think outside the box, be prepared to be disowned by your former community if you undergo surgery and have relief from your CRPS pain. I would say that just my experience as a pain-focused peripheral nerve surgeon is that most people who have severe neuropathy pain could at one point or another be diagnosed with CRPS. Many times it's just the luck of the draw in some sense. It depends on how focal their pain is. and it depends on if they show some of these more sympathetic symptoms or not as to whether or not they get diagnosed with CRPS. Um, other than that, once you get past that mental block of, there's nothing that can be done for CRPS, and specifically surgery is the number one worst thing you can do for CRPS, then basically you're just like any other peripheral nerve patient. And, whether somebody comes to me with a diagnosis of CRPS or with a diagnosis of, some type of chronic pain or even nerve pain or what have you, you can pretty much treat a CRPS patient like any other patient. It all has to do with just doing an appropriate, comprehensive, detailed peripheral nerve evaluation and figuring out where all the pitfalls lie. And sometimes that involves a spinal workup as well, just depending on where the patient's symptoms are. I don't really know that there's a lot else to say about CRPS. It's not a really detailed topic. Obviously, CRPS can involve pretty much any nerve or combinations of nerves in the body. It is important to try and address the problem early on. If you have somebody who's had quote unquote CRPS for a decade, the chances of you being able to really do a great or give them a great result is certainly lessened versus somebody who's had it for 6 months or a year or even less time. So treating it aggressively and treating it early is important for good outcomes. So let me address one other issue, is that surgery is not, or let me address it this way. So chronic regional pain syndrome, CRPS, is think of it as a bucket that a bunch of people are dumped into who don't all have exactly the same problem. There are certain people who have a type of condition that's also labeled as CRPS that is probably not amenable to surgery, and these are patients who may develop an illness, a pneumonia, a viral illness, some other thing, and then go on to develop this sort of whole body CRPS where everything might burn from head to toe, including internal pain, etc. Most likely those patients don't have a peripheral nerve problem, or at least the main issue is being mediated centrally, meaning it's something going on with the central nervous system and not due to a peripheral nerve problem. Now, in some patients, you might start out with an obvious peripheral nerve problem, and then over years where things aren't addressed appropriately, there are some patients who can just, sort of develop this whole body CRPS. I think there definitely can be a central component to CRPS. So the longer pain pathways are sort of set up, you can get changes in the brain that can be involved as well, and that isn't directly amenable to surgery. Although sometimes if you can address the peripheral nerve problem, then those pathways that have been set up in the brain can sometimes remodel as well over time. But for patients who sort of have, especially where they don't have a traumatic etiology to the onset of the CRPS, meaning they didn't injure themselves and they didn't have a surgical procedure preceding the CRPS. So patients who develop some kind of medical illness where they may have had to be in the ICU and then all of a sudden just develop CRPS everywhere. Their face burns, the inside of their mouth, their tongue, internal chest or abdominal pain, and then everywhere else in their body as well. That's typically not something that's going to do well with peripheral nerve surgery, because there's, it's not a peripheral nerve problem at its core. Let me go through some of these questions that people or comments that people are making. So I think I addressed the first one. There's one here about ketamine, and it says ketamine works great for my son. I would say that with in terms of peripheral nerve problems generally, if you find something short of surgery that works well for you and it's manageable, you're not having to spend thousands and thousands and thousands of dollars every month to keep doing it, or maybe that's not an issue for you. If you found something that works for you, whether it be ketamine, whether it be um, physical therapy or dry needling or what have you, and that's working and it's making it manageable, then that's great. That's, continue doing it. That's what I would say to that group of patients. But the vast majority of patients who have severe peripheral nerve problems, including CRPS patients, do not respond effectively to ketamine. So if ketamine works for you, do the ketamine. If it doesn't, then there may be other things that might. You really don't know if surgery is a good option for somebody with quote unquote CRPS until they've had an evaluation and the physical exam component of it. This commenter said that the ketamine works great for their son. They have to have these infusions every few months. Typically, my understanding is that those are not covered by insurance most of the time, so that gets to be quite expensive over time. And even though it's working now, it may not work in the future. Again, if it's working now and you're happy with it, I would say continue doing it, but just keep in mind that if the ketamine infusions stop being effective, that there may be additional things that can be done rather than just psychologically having to talk yourself into living with the pain. Another commenter says, "Hi, how are you? It's hard to get into see you now." I assume that's what she's saying. Yeah, I mean, everything's kind of hard now. Myself and my staff are fine. We're here in the office. It is pretty slow just because the majority of my practice, as a doctor, I've probably been more affected than other physicians who generally have their practice locally based, because most of my patients, probably at least 80+%, come from out of state. And so with the restrictions and people, understandably being worried about traveling and all that, things are a little bit slow. So, once that goes away, and I think it will here in not too much longer, things should return to normal. The commenter here says, "I get injections in the knee every 3 months for pain." So the question is, if you get an injection every 3 months in your knee for pain and it takes it away for 2.5 months, and then you sort of get back to the point by about 3 months where you need another injection, most likely the source of that pain is that you have fairly advanced osteoarthritis in the knee. When you say knee injections, almost certainly they're injecting something into your knee joint, probably a combination of steroid and local anesthetic, or there's other things that they can do. But if that's effective for you and allows you to be walking around on that knee, and then you need another injection every 3 months or so, that's probably due to osteoarthritis and not a nerve problem to begin with. And if that injection ever quits working, that's where you're likely to be at a point of needing some kind of knee surgery, whether it's an ACL reconstruction or meniscus trim or even a total knee arthroplasty. But that sounds to me like probably a musculoskeletal issue involving arthritis in the knee joint. There's another commenter here that says, "I need help with burning sensation in left upper thigh." So just from that description, this person is most likely dealing with a compression neuropathy of a nerve called the lateral femoral cutaneous nerve, which innervates both the front and sort of side of the thigh, and generally covers a region from about the hip down to about the knee. Now, somebody with lateral femoral cutaneous nerve compression or injury, both can produce similar symptoms, may not have burning or pain throughout the whole range of the thigh. As with any other peripheral nerve problem, it can be variable in terms of where the symptoms are actually felt, even though it's the same nerve being compromised. So some patients with a lateral femoral cutaneous nerve compression, the other name for that is called meralgia paresthetica. People with that kind of a problem can have an entire thigh that burns. They may not really have burning at all. They may just have deep aching pain or sharp stabbing pain. The pain involved with that nerve can be predominantly very low down by the knee. And so some patients with a problem, involving that nerve can actually, they will tell the doctor that they have quote unquote knee pain, even though it's really not the knee, but the tip of that nerve or the terminal part of that nerve innervates the upper outer quadrant of the knee. And so some patients, the pain is perceived most predominantly right at the distal or terminal branch of the nerve. But in somebody who tells me they have a burning sensation in the upper thigh, my recommendation would be to find a pain management doctor and have them block your lateral femoral cutaneous nerve. They can do that with just local anesthetic or local and steroid if you're just trying to get a therapeutic benefit from that. But that's probably what that commenter is dealing with. There is a very good solution for the problem if a steroid injection doesn't give you relief, in that depending on the history, if the nerve is likely to have been damaged by prior surgery or trauma of some sort, then the best thing to do is actually disconnect that nerve. It's not an important nerve. You will be trading some numbness of the skin to get rid of the pain, but it's not a motor nerve, so you don't lose any function of the leg. If there's no evidence that the nerve has been compromised in any way and looks to be just compressed, then you can decompress that nerve just like you would somebody who has carpal tunnel syndrome, and most often they will have a good result from that as well. Just going through some of these other comments. There's a commenter who says, how long is the recovery from peripheral nerve surgery? I would say that it really depends on the type of the problem and how complex the procedure is. Peripheral nerve problems can be addressed through something as simple as a couple centimeter long incision, on an extremity somewhere, which basically you're more or less good to go the next day almost, to something that can take 3, 4, 5, 6 weeks to really recover from, depending on how big the surgery is. I will say though that most pain is a very individually experienced phenomenon, so you can do the same thing on 2 patients, and one may be sort of ready to go back to work in a week and the other one might take 4 weeks. So everything that I do pretty much is done in an outpatient surgery center setting, so it's not huge major surgery like if you have abdominal surgery or surgery on the chest or something like that. The pain post-op is usually very manageable with some oral medication, and recovery is not all that big of a deal, I would say, compared to a lot of other types of surgeries. The other thing about peripheral nerve surgery is you can typically be weight bearing immediately with the limb that's been operated on, if in fact a limb was operated on. It's not like a lot of orthopedic surgery where you're waiting for a tendon to heal or a bone to heal, and so you have to be non-weight bearing for sometimes months at a time. It's actually important to start walking on the operated limb right away to some degree, and that varies depending on what the surgical procedure is, because you want nerves gliding through the scar tissue bed as it forms. I have a question here. It says, do neurologists understand CRPS? That's an emphatic no. Neurologists don't understand CRPS. Pain management doctors don't understand CRPS, and neither do any other doctors really. I mean, they understand it in terms of what it's understood to be within the larger medical community, but none of them understand that most of these patients, the underlying problem is a peripheral nerve injury that can be surgically corrected. That's the real key to CRPS, is that for most patients, not all, not 100%, but probably at least 80% of patients with CRPS, there's an underlying peripheral nerve problem that can be identified and surgically corrected, giving the patient complete or very good relief from the pain that that's otherwise pretty debilitating. CRPS pain, sort of, oftentimes you'll hear people talk about it as the worst pain that you can possibly experience as a human being. And I wouldn't disagree with that characterization, but that's sort of for nerve pain generally. It's by far the most severe type of pain you can experience. Another question here about spinal cord stimulators. Do they help? Generally speaking, spinal cord stimulators are very ineffective for peripheral nerve problems, and that would include CRPS. They can be the one place that I think spinal cord stimulators can be effective for long term is where a patient has spine pain or pain that's pretty limited to the spinal column itself. Once you're trying to treat a patient who doesn't have an obvious source for the pain at the spine level, they have, especially if there's no radiation of pain from the spine down through the leg, but just some kind of pain that may sort of start around the knee and go down to the foot. It's very, very unlikely that a spinal cord stimulator is going to give that person long-term relief. My experience with spinal cord stimulators is that if very often a patient will do well with the trial and then not do well with the permanent, and that's kind of a strange thing. They have a trial in for 5 days, it does great for them, then they put the permanent stimulator in and it doesn't work at all. Also very common are patients who get the permanent spinal cord stimulator implanted. They do well for a period of months, maybe even as long as a year, and then it just kind of stops working for one reason or another. A lot of times that can be because the lead gets pulled or shifted in terms of the level it's affecting. But very often, even when that's okay, it just stops working. What a spinal cord stimulator does essentially is it runs interference for the brain. It provides a source of white noise, if you will, to the brain, which sort of makes the brain forget about the pain signal. But if you remember the original Jurassic Park movie where Jeff Goldblum, his character, famously says, "Life will find a way." That's always what I think about with spinal cord stimulators, because eventually the brain sort of figures out that it's being tricked, and then the pain will come back, and that can be a matter of weeks, months, or even longer sometimes. But spinal cord stimulators, generally speaking, are not a very effective treatment for peripheral nerve problems. A patient here says they have CRPS. I have CRPS in my knee and I'm unable to walk for 4 years. Is that too long to be able to now correct with peripheral nerve surgery? I have tried everything else. So I would just say that the more localized, just generally speaking, the more localized pain is, so like pain in the knee that's been designated as CRPS, you have a much longer window of time to usually take care of something like that. There's a patient that I had come to see me from Mexico, who some of you may be familiar with, who basically was given a diagnosis of CRPS and who wasn't able to effectively walk for almost 25 years. The source of the problem was actually mainly a saphenous nerve. There were some other issues, but that was able to be identified and fixed surgically, and she now walks very well. So 4 years is certainly not long enough, and I would say that that's not a hard and fast rule. It's just the longer you've had a problem and the more complex the problem is, so the wider of an area of the body that it affects, and depending on other factors like how many other surgeries you've had, opportunities for nerves to be damaged versus just compressed or something like that, all these factors go into it. So just in general terms, the more complex the problem and the longer it's been there for somebody who's been given the diagnosis of CRPS, it does cut down on the chances of having complete relief or sometimes even a great outcome. So getting to these problems earlier on in the course of disease is always increases the odds of a great outcome. There's a comment here that says, would dry needling help? Would help EP. Not exactly sure what EP means off the top of my head. Again, then she just corrects that it says MP, not EP, so that must have been talk to text or just a typo. So I would say that for any type of a peripheral nerve problem, dry needling can be effective in very mild cases. Things like physical therapy, dry needling, cupping, injections, both local anesthetic injections or steroid injections. All these things, these sort of minimally invasive and more quote-unquote conservative measures can be effective for mild to moderate cases. And most of the time, patients rarely find me first. Almost always they go through the whole gamut of sort of standard treatments that are out there for nerve pain issues, and most of the time it doesn't work. unless, like I say, unless it's a mild to mild moderate problem, then it may work. It may either sort of manage the problem long term, or it could actually resolve the problem initially. And mild to moderate symptoms typically mean a mild to moderate injury in the first place. And peripheral nerves can regenerate and heal themselves. And that's usually what's going on, probably more so than whatever the treatment is. Although, again, if there's like some sympathetic response initially, sort of calming that down with steroids or epidurals is a good thing and can really be beneficial. But probably for most of the other things, if somebody's doing it and the symptoms, typically what you'll see is in a patient who has a good outcome and resolves it is that they weren't really severe to begin with, and then it's probably a situation where the underlying nerve injury wasn't that severe, and that just tincture of time more than anything else has allowed that nerve to just heal and become asymptomatic again. But it certainly could be the case that some of these other treatments like dry needling are doing something. And so I wouldn't discourage anybody with mild to moderate pain symptoms, especially if it looks like nerve, to give that a try and see what it does for them. So somebody asked if someone has had nearly 3 years of CRPS as well as atrophy meaning the bulk of the muscle tissue is sort of wasted away a little bit, but the pain has gotten better as well as mobility, can surgery still possibly help? So I guess what I would say to that is you have to take stock of how much pain you're still dealing with and how much that's affecting your quality of life. One of the overarching principles about considering peripheral nerve surgery for any reason is how much do the symptoms associated with the peripheral nerve problem affect your quality of life? And that's a very individual question. It's not something that I, as the physician, can generally answer, although, I typically tell people if they're experiencing significant motor symptoms, so whatever the peripheral nerve problem, it's affecting muscles, that's something to really consider as more of an urgent problem, because over time, if you don't address peripheral nerve problems that are affecting muscles, meaning making muscles weak or even causing muscles to waste away or atrophy or become smaller, sometimes if you let that go too long, then those changes can be irreversible. So that's the one thing that I generally counsel patients to really consider surgery earlier rather than later. But that scenario occurs only a small minority of the time. Most people, it's numbness, pain, and the impact on their quality of life that is attendant to those symptoms, particularly the pain. Pain is by far the most aggravating symptom that comes with a peripheral nerve problem. When patients just have numbness or even develop a lot of weakness, very often they're not that motivated to find a quote unquote cure for their problem. It's when people have severe pain that they really keep looking and looking and looking, and that's how they generally find me. So somebody who's had 3 years of those symptoms, but has had the pain is reduced and their ability to move and function is better. It really depends on what's the status of the clinical situation right now. If it's still significant enough that you're not sleeping well, you're feeling depressed or anxious, it's affecting your relationships with loved ones, or you're not able to work, or all these kind of things, then those are the level of symptoms which surgery is, the risk of surgery becomes very small in comparison to the potential benefit of surgery in terms of relieving those symptoms. If on the other hand you have some pain, but you're able to control it with an occasional pain pill or by doing dry needling, you're pretty functional, you're sleeping okay, it's not affecting your interpersonal relationships, you're not depressed, you're not suffering from anxiety, you're managing with it, then surgery is probably not needed or necessary. Everybody can tolerate a certain amount of pain and be happy and function well in their life. It's just sort of once you get beyond that, there's a tipping point beyond which it becomes too much, and that's really where surgery becomes a valuable tool in trying to deal with these problems. There's a question here about will will MR neurography show an abdominal wall nerve entrapment / inflammation? Is that a peripheral nerve? MR neurography is certainly not a magic bullet. It's the best type of MR imaging that we have, and therefore it's the best imaging that we have to try and see problems that are involving peripheral nerves. But generally speaking, if it's going to show something, it'll be much more likely to show it on a large nerve versus a small nerve. It's one reason why I like to get it for people who are suffering or appear to be suffering with piriformis syndrome, because that's the most likely scenario in which it's going to light up and show inflammation around the nerve. When you're talking about the abdominal wall, the nerves that are running through the abdominal wall are so small that most of the time, unless you had a big neuroma or something, most of the time an MRI imaging, even an MR neurography, is going to probably be negative or not show much. If you have inflammation of the soft tissue generally in an area where it's painful, that may light up, but just isolated inflammation of a specific intercostal nerve running through the abdominal area is unlikely to show anything on MRI imaging and even MR neurography imaging. And that's one thing about, one reason why these peripheral nerve problems are so hard for doctors in general to identify, beyond the fact that they don't understand the anatomy very well. Peripheral nerve problems just generally don't show up on any kind of imaging. And so, you image where the patient is telling you they're having excruciating pain and it'll come back normal. It looks normal. And so, what do you do with that as a doctor? It makes no sense to you. That's why a lot of patients who have diagnoses like CRPS or just peripheral nerve problems in general will often start to be viewed as drug seekers or crazy. It's sad, but that happens a lot to patients who have who suffer from peripheral nerve pain, because very often they look totally normal. Let's see. There's another here says, another commenter says, my worst symptom of CRPS in the leg, foot is constant spasms. I have temperature and color changes as well. Would that sound like a nerve problem? That sounds like a classic peripheral nerve problem right there. One thing that's important to remember about peripheral nerves is they generally have three main functions. They have a motor function, so certain fibers within a nerve. Well, peripheral nerves can be predominantly motor, and what that means is that nerve, its main function is to make a muscle contract and therefore produce movement in the muscle. Some peripheral nerves have primarily a sensory function, so what they're doing is they're innervating an area of skin. They may also innervate structures within tendons and muscles that pick up on stretch or pressure. They innervate joints, etc., etc. So they don't make muscles move. They primarily relay information to the brain about how the environment of the body is doing, and specifically pain. And then sensory nerves also relay information about sensation. So, if your fingers are starting to get numb, you have less ability to tell what you're touching unless you're directly looking at it. And then nerves that tend to be usually bigger can be mixed motor and sensory. So the sciatic nerve, for example, which is the largest nerve in your body, has a lot of the fibers that are running through the sciatic nerve at the level of the buttock, for example, are motor nerves, and a lot of the fibers are sensory fibers. So it's a mixed nerve. If you look at the nerve, it looks like one big nerve, but there's both motor fibers and sensory fibers there. And then, the way to think about the sciatic nerve is sort of that it's an upside down tree. The trunk is at the buttock level, and as it goes down further and further down towards the tip of the big toe, it's giving off branches here and there. And as the branches get smaller and smaller, they're more likely to be just purely motor or purely sensory. And so in anybody that has a peripheral nerve problem, whether you've been given the diagnosis of CRPS or not, one very common symptom that can arise is either the sensation or the actual reality of a muscle contracting. So some people can have pain where it feels like a horrific cramp in the muscle or a Charlie horse in the muscle, and yet the muscle is not actually contracting. And in other patients, the nerve problem can actually produce or cause the muscle to contract violently and cause that pain. And then you'll see whatever the muscle is attached to, so it may pull your foot down or pull the toes up or something of that nature. In some patients, it may not be a painful sensation, but it can cause movements of the muscle called fasciculations, and these can be mild or severe, where the muscle just kind of rise like there's worms under the skin or something like that, and that's very commonly due to a problem with a peripheral nerve upstream. So the manifestation of the problem is the muscle cramping or feeling like it's cramping or actually moving or fasciculating, but the actual problem can be very remote from where you're visualizing the clinical symptoms, and that's another reason why these issues can be hard to identify if you don't know how to fully examine the peripheral nervous system. There's another commenter here that says, my orthopedist says my nerve is trapped between the scar tissue, causing the pain. This comes to an infection and bleeding in the knee, but the pain relief does not always work. So I'm guessing in that scenario that this person has probably had knee surgery before. There's a complex web of both large and small nerves transiting through the area of the knee joint. And so any surgical procedure that, whether it's an arthroscopic procedure where they just poke, 2 or 3 holes in the knee area, or all the way up to a total replacement of the knee joint if it's very arthritic, can result in a situation where some of these smaller nerves generally can actually be physically damaged, and sometimes the larger nerves that run through the area can become compressed. Nerves in many locations throughout the body pass through tight spaces, which in normal times is fine and there's no clinical symptoms, but if you introduce bleeding or swelling or inflammation to the area of a nerve where it's passing through a tight space, typically what happens is that the tissue that forms the tight tunnel or constricting space around the nerve tends to shrink and contract and then cause the nerve to become or to start experiencing mechanical pressure, which is a very painful scenario for the nerve. And so it's possible that in this case there are nerves that are stuck in scar tissue, so that when the patient is bending their knee, instead of that nerve being able to glide back and forth through the tissue, it's actually sort of fixed to a specific point. And a good way to think about that is sort of like if you have a rubber band and you have the rubber band fixed to 2 points, and both points are moving so that rubber band can slide along as it moves across a knee joint, for example. In a situation where there's a lot of scarring around that knee and the nerve gets stuck into the scar so it no longer is able to slide, now when the knee is bending and the patient is moving, it's like that rubber band is being stretched rather than being allowed to glide smoothly through the tissue. And that's also a scenario which can generate a lot of pain through that nerve that's being stretched like that. So, most likely if there's scar tissue around the knee, it's because there's been prior surgery, but the same thing can happen from just an injury. Some people end up getting a total knee replacement because they fell hard on their knee and landed on cement, and it crushed or damaged one of these small nerves that innervate the area, the soft tissue envelope around the knee. And then what ends up happening is the patient has this horrible knee pain that doesn't go away, and nobody knows what the source is. They get the x-rays and what have you. And the older the person is, the more likely they're going to end up with one or more knee surgeries culminating in a knee replacement for what is really a peripheral nerve problem. And I've seen that many times. I have another commenter here who says, I have CRPS in my right hand. My edema has gone down, but my hand still flares so bad. My doctor seems to feel that it should be feeling better since the swelling went down. So this is sort of a classic scenario. Some of those early sympathetic motor visual manifestations may have resolved, like the swelling, maybe like the color changes, or the skin being real shiny or smooth. There's all these different things that one can experience due to that sympathetic motor response. Um, and once that sort of goes away, the patient can be left with still excruciating pain, but now they look normal. So their doctor's like, well, that you should be feeling better because all the things that I could see with my eyes have gone away. Um, and so, that person is somebody who could almost certainly be fixed with peripheral nerve surgery if more conservative measures have not worked so far. Meaning, the injections, the sympathetic blocks, other things. Very often in patients with CRPS, they don't really tolerate a lot of conservative stuff because touching or moving the limb or the hand that's affected can just cause excruciating pain. So, if you have somebody who's going to physical therapy, whether they have a diagnosis of CRPS or not, and they're crying after their physical therapy session because the therapy itself is producing so much pain, that's almost certainly somebody that should stop therapy and should seek out a pain-focused peripheral nerve surgeon because they probably have a peripheral nerve problem. And when that scenario is present like that, all physical therapy is doing is just making the situation worse. It's not helping. Patients who will respond to physical therapy for a run-of-the-mill musculoskeletal problem will almost immediately start to see improvement with therapy. And certainly after a couple of weeks, they notice that things are getting better and better and better. If somebody keeps going to therapy and they're crying after every time they get out, or it's causing just excruciating pain, that's a big red flag that you're probably dealing with a peripheral nerve problem and not just a run-of-the-mill musculoskeletal issue. I think that's we're about at an hour here. I think that basically we've covered most things associated with CRPS. The big takeaway point I would say for CRPS is that it's not a diagnosis that you have to live with necessarily. For probably at least 80% of patients with CRPS, there is a great surgical solution waiting, but you have to be brave enough to sort of at least go for the evaluation and to not listen, especially those who may be in there's these innumerable CRPS support groups. You have to be able to think independently enough to not just accept the dogma that there's nothing that can be done for this condition. Understanding that in most patients who can be fixed, they actually have just an undiagnosed peripheral nerve problem that if diagnosed properly and treated with the appropriate surgical intervention, they can have a great outcome. Looks like answered all the questions that I've gotten so far. So I hope that was informative for any of you out there with peripheral nerve problems and specifically CRPS in general. Do not give up hope. It's except for that one group that I mentioned where it's sort of like their entire body, which that's typically not likely to be something that can be helped surgically. But that's a very small minority of CRPS patients. So for the rest of you, if you're really dealing with severe symptoms, there is potentially a good solution for it. And I'll just leave that there. Thank you everybody for tuning in, and I hope this was informative. Have a good day.